We now move on to the competitions. The poster competition is already on its way. We have our judges, our jury members, Sharmista Nai ma'am, DGM Nursing, KD Hospital, President Gujarat Chapter, Annie, Ma'am Upama De, Professor cum Principal, College of Nursing, Tata Main Hospital, Jamshedpur, President Jharkhand Chapter, Annie, and Professor Dr. Simple Rajgopal, Principal, Sri Narayana College of Nursing, Ernakulam, Member, Kerala Chapter, Annie. A huge round of applause for them.
We now move on to the next segment of the ANEI competitions, a platform that celebrates innovation, leadership, and excellence in nursing practice. To evaluate today's competition categories, may I invite our esteemed jury members, Dr. Falakshi Manjrekar, Director Nursing, PD Hinduja Hospital and Medical Research Center, Mumbai, and Member ANEI. Madam, please come on the dais. I would also like to invite the second jury member, Dr. Rita Lakhani ma'am, Managing Editor Nursing, JP Brothers, Medical Publishers and Member ANEI. We welcome you, ma'am. And we would also like to welcome Major Anjana Williams ma'am, Group Director Nursing Services, Ruby Hall Clinic, Pune and Member ANEI. Please give them all a huge round of applause. So we begin with the first competition, Future Nurse Engagement Challenge. It is now my privilege to invite our first finalist, Ms. Dolly Bishwas, Chief Nursing Officer, Fortis Hospital, Anandpur, Kolkata, and National Secretary, ANEI.
Good morning once again to everyone. I know that very engaging session and mind-blowing conference that we are presenting, that we are attending since yesterday. And I give kudos to entire Maharashtra team who has organized such a fantastic way this conference, and give a big hand to Maharashtra team, entire team. Thank you, Dr. Elizabeth Joseph and her team for organizing such a mindful event. Thanks to all the juries over here sitting, Dr. Rita, Madam Falakshi, Madam Ranjana Williams. Thank you for your time. So let me take you through my quality improvement projects. So we know that since yesterday we are listening to our students, our very young advanced beginner nurses and novice students, that how much important it is to handhold the student at the clinical field, nurturing them, guiding them, and giving them, an empathetic way of handling, or giving them a confidence at the clinical field is very, very important. And sometimes we lack with that. So here is the project, the session, Strengthening Clinical Competency Through Hospital College Clinical Partnership Model, a collaborative learning approach for nursing students. As we know that when a clinical training is just getting over, or a student nurse is just entering into the collegiate education from the first year of nursing, it is, from a theoretical background or from a demo lab, shifting to the actual clinical field, giving a cultural shock to them. And there the seniors needs to handhold them and cajole them or train them adequately. And if there is any lacking been found, then only the student nurse feels very, tensed, and they are not able to accept the nursing truly nursing from their mind. So here it is written over here that clinical training is crucial component of nursing education, and bridging theoretical knowledge and practical training is important. However, many students face challenges in translating classroom learning into the clinical practice due to limited structured mentorship program. So keeping in mind that we have done a baseline studies, because being a corporate hospital, we do not have our college, but we engage the college, other colleges, those who are not having a hospital, to engage them to our clinical practice, where the clinical baseline data says 61% of clinical competency they are having, limited confidence, which in the Likert scale shows 3 on all the points out of 5, and inadequate participation in the patient initiative activity, where it scored 27%. And primarily due to this absence of structured training system and weak collaborations between hospital and nursing college necessitate the comprehensive clinical partnership model. And there we go. Therefore, a hospital-college clinical partnership model was developed to enhance the collaborations between healthcare institution and nursing college. The model focuses on structured mentorship, competency-based training, and active students' participations. So our aim was to strengthen the clinical learning competency and development among nursing students through a structured hospital-college partnership model. And our objective framed as to improve the nursing students' clinical competency and confidence in patient care. Number two, to establish the structured mentorship between student nurse and the nursing staff nurse and the nursing students, and to involve nursing students in quality improvement and patient safety initiative, and to enhance the collaboration between hospital staff and nursing college faculty for better clinical educations. We have seen that if a student nurse who has come to us to get the exposure, if a staff who is not hand-holding the student or not helping them to learn them how to check even a simple blood pressure, like tying the cup at 3 finger above the antecubital fossa, and then raising the pressure and feeling the pulse first. Radial pulse must disappear. You put the stethoscope and then you start raising the pressure again, at least 20 mm of Hg, where the pulse get disappear, and then you start receiving the coroscope sound by releasing the pressure. The first coroscope says that it's systolic and the last disappearing sound is diastolic. These minute observations, if a staff or a clinical instructor or a tutor is not teaching the student will be unlearned throughout the life. So that is why it is very, very important to make the student to learn how is this actual observations required at the clinical field. If a staff nurse doesn't know antithyroid or a thyroid medications not to be given along with an proton pump inhibitor, what is the rationale? What is the reason? If our experienced staff is not saying, the student or the staff will never be able to know, because the efficacy of the drug, the action of the drug get completely diminished if it's given with the proton pump inhibitor. If a student nurse never heard about the Birmingham sound of the abdomen, the student will not be realized when to give a sips of water to a patient, only will be relying on the doctor's note, not on the own experience that Birmingham sound is important before starting a sips of water for a post-operative patient who is anesthetized. And there the mentorship comes, and every staff nurse or a senior nurse must understand how much it is important for a student nurse to help to learn all this nitty-gritty, which Dr. Narayani said yesterday, a nitty-gritty to be looked into by the senior nurse in the clinical facility or the clinical field. Simultaneously, when our third year novice student yesterday was lecturing and saying, our patient loved us very much. Why? Because when a bell rings, and we first, the student would run to a patient's side and ask them, sir, do you need anything? You see, so when a student runs, because she is new to the area, and she is having motivation to learn, we need to uplift that motivation. We need to support them. So here we go. The project type was educational innovation project, bridging the theoretical knowledge to clinical practice. Setting, tertiary care hospital, Fortis, affiliated with the nursing college, Sister Florence Nursing College of Kolkata, who is not having a hospital, and the Tripura Institute of Nursing Student. Participation, student nurse 60, fourth year, and the 60 clinical mentor. Who are these mentors? These are none but our staff nurses. So we have 20 wards, 20 different wards, a respiratory ward, a cardiac ward, a general ward, many, private ward. So like that 20 wards, we have given three nurses to each, posted with 6 or 5 allocation for a 5 twin rooms, and with each student given each staff given one student to play the mentorship role. Along with that, college faculty members were around the clock there. Duration of 6 months. Data collection tool, we have used clinical knowledge questionnaire, clinical competency checklist, clinical attitude monitoring checklist, clinical confidence assessment like a scale, student feedback questionnaire, mentorship evaluation form, and patient safety participation record. Here we go with the intervention. Structured clinical orientation program is given to on basic hand hygiene, infection control practices, basic patient care. Clinical mentorship program, which comprises student assigned to a instructor, the clinical mentor, those were the staff nurse, and mentor provide bedside guidance and supervision for each procedure that the staff nurse performs and given the guidance to the student. And skill development session also done, weekly clinical skill demonstration. We have a very good high fidelity mannequin simulation lab. So there also we have given opportunity for the student to practice, and then simulation training and case discussion also done with the students. Student participation in quality initiative, which were lacking. So we motivated them to participate into the infection control week, in patient safety week, as well as in hand hygiene week, and fall prevention monitoring program, and 5 mandates of medication administration program. Monthly academic clinical review done jointly with the student and their clinical tutor and clinical instructor. What was the result? Improved clinical skill performance among the nursing students that we have started seeing, and better integration of theory and practical clinical care, because each rationally been explained to them why you are doing, how you are doing, increase awareness of patient safety, stronger collaboration. These are the, every orange color bar which is showing that how much percentage has improved from their baseline data on patient care, patient safety, infection control, hygiene, clinical attitudes. Everything is depicted in this graph which you can see over here, and every moment, even the roster planning, how it will be there with the staff nurse and the student, that was being taken care by the in charges. And these are the attitude also been measured with the clinical graph which you are seeing. The orange bar is showing that there is an enhancement of the students' knowledge from 61% to 84%. So discussions here, not only the knowledge, the clinical practice which has improved, where we have seen the 23% of clinical practice has improved, 24% of attitude has been improved, and then we have developed that, concluded that this kind of mentorship program where one staff nurse will get one student and handholds them and train them each and every procedure, and the knowledge which needs to be learned to them, encourage them, motivate them to practice at the clinical field and attains all kind of safety program. That's the sustainable model and the way forward that is been narrated. Scale up the model, not only with the 4th year, but with each and every year students. Right from the 2nd year, 3rd year, 4th year, if we can practice this model, student will learn. Strengthening the mentorship program is our motto, and to sustain it, simulation-based learning labs to be used full-fledged, giving the opportunity not to lock the lab, but let the student learn. But yes, our clinical instructor also has to help them out, and continuous evaluation feedback taken, and sustainability also measured. I think the last slide is not been, something is wrong. Anyway, that's the end of my slide. So thank you very much for your patience hearing. There we go. I must tell the staff nurses, a lot of college instructors are sitting here, quality nurse, in charges, senior nurse, chief of nursing, deputy nursing. Please give the opportunity for the students to learn and grow and flourish, to take our profession to an highest level. That is what we want to see, and that is the future nursing. Thank you very much.
Thank you, Dolly ma'am, for your presentation. Our next finalist is Professor Delphina Mahesh Gurav, Vice Principal cum IQAC Coordinator, SMES, Srimati Sunanda Praveen Gambhirchand Institute of Nursing and Paramedical Science, Mumbai. May I invite Madam Delphina to deliver her presentation.
Thank you so much, ma'am. Namaskar, Mumbai. Namaskar. Okay. So here, I must say that all of us seated here at some point of time have lived the journey of a novice nurse. The transition from being a student to staff nurse is at most difficult, however knowledgeable you must be. I must say that we do go through a fear, apprehension, and the fear of unknown. What is it going to be? Whatever we have learned in our college life, it is entirely different when we step into the field of clinicals. And there we thought of, bridging the gap between the classroom to the clinical practice. We at Seva Mandal Education Society, although the idea was conceptualized by me, I had a team of a very abled principal, Madam Shilpa Shettigar, Namrata Choprekar as the then HOD of the department, and Ms. Sonam Gupta as the coordinator who helped us implement this project. So here I am presenting our idea. Although it is a very small project, but we thought that it is definitely a very, very helpful project that is sustainable and practical to deal with. So here I begin with my project. There we go. So respected dignitaries and my dear colleagues, here am I presenting the topic Closing Classroom to Clinical Gap through Alumni-Led Clinical Teaching Cell. So the background, the need that we felt, as I just mentioned, that the transition from clinical learning to real-world clinical practice remains a significant challenge for all the nursing students, often resulting in reduced confidence, skill gaps, and difficulty in clinical decision-making. And definitely, this is a threat to the patient safety. So students primarily in the college acquire the theory-based knowledge from the textbooks. However, the science changes every day, and as we know that real-time data keeps on changing, which takes time to come into the textbooks. So how do we bridge this gap? Whatever is new and yet not in the textbooks. So you will find that definitely there's a significant gap which exists between this static learning and the rapidly evolving technology-driven and patient-centered trends in the contemporary healthcare. So leading to challenges in real-time clinical application. Whereas, why did we tap the alumni group? Because alumni bring practical insights, updated clinical practices, and contextual problem-solving abilities in the real-time scenarios. So we thought of integrating alumni-led clinical sessions into the curriculum, and through the exposures that, the real-time exposure that the alumni have, we thought that they could be tapped and utilized to actually teach the students, what are the in-between things that they should learn in the clinical practice. So this initiative aims to bridge the gap by engaging the alumni who are practicing nurses as clinical educators and mentors. This approach strengthens the academic clinical integration, promotes experiential learning, and also nurtures a culture of mentorship within the institution. So the aim was to enhance the clinical competency and readiness of nursing students by integrating them both, and the specific objective was to bridge the gap between theoretical knowledge and the clinical application, to familiarize the student with current hospital protocols and practices, to build confidence and reduce anxiety among students during their clinical postings, and to promote professionalism, socialization, and mentorship through alumni interaction. So we had taken a quasi experimental educational interventional project, and undergraduate 200 students were our samples, and we had excluded the students who were absent during these sessions. The findings that we came across, it demonstrated a marked improvement in knowledge, skills, professional competences among the nursing students following the alumni-led clinical teaching. Across all domains, post-test scores were consistently higher than the pre-test scores, indicating the effectiveness of the program. And the overall interpretation showed that it resulted in a positive shift in all the learning domains. The highest improvements were seen in ICU management and emergency care, which are typically difficult to grasp. The findings confirm that experiential alumni-led clinical teaching enhances the cognitive, the psychomotor, and the affective domains. The program effectively reduces the gap between theory and clinical, making students more competent. And the most satisfactory outcome of this project that we came across is enhanced visibility of the students, their efficiency compared to the novices that were admitted and enrolled in that particular parent hospital of ours. And we would get the feedback from the consultants, the senior nurses, about our students being outstanding, even than the novices, the new enrolled nurses. So the areas that we projected, there were many areas, but I have only projected the very important ones. So we thought of cath lab responsibilities, ICU management, nurses' role in emergency, professionalism. In professionalism, there were various domains that were taken care, how to deal with patients' relatives, how to deal with patients, how to, in between whatever communication is required in the hospital. Those domains, quality indicators, oncology, advanced care. So you could see that all the domains, the pre-test and the post-test, there's a vast difference that was seen. Also the feedback from the learners showed that they want these sessions to happen on a regular basis. And not only that, the clinical narrative that the reflections that were received from the healthcare experts on this alumni-led clinical teaching showed that every aspect, whatever we had dealt, actually ranged above 4.52 out of 5. So here I conclude that this study highlights the effectiveness of alumni-led clinical teaching as an innovative strategy to bridge the gap between the theoretical knowledge and the clinical practice. It's the key finding shows a significant improvement in clinical competence and confidence in their students. Unlike traditional classroom, alumni bring contextual real-time clinical exposure, making learning more relevant and application-based. And I must proudly say that all those alumni who have actually been out from our students have lived the life of the student and also the transitional life from being a staff nurse from the student. And therefore, they were the right tapping, resource, which we thought that they could give the right examples, how they felt from being student to getting into the staff nurse position. And what is the gap actually? So these small things are very, very necessary, which we felt would make them confident enough. And believe me that when we took the first competency assessment of our students, after placing them in the clinicals, the stakeholders' response, the senior nurses' response, and the students' response itself was so overwhelming for us that definitely there was, that fear was gone, the apprehension was gone. And the students felt that, yes, they know how to deal with all this situation. So we feel that definitely this study has a significant relevance in enhancement of clinical decision-making skills, better visibility of the students, efficiency compared to the novices which are enrolled. So the way forward, so these are some of the glimpses, the alumni who proudly want to get back to us with their clinical competence, the thing that they have not learned in the college and now that they are doing, they want to share with us. So because an alumni group we shared, it had a ripple effect, and now more students, more alumni want to bring their knowledge back to the college, and that's how we are bridging the gap. So the last concluding slide, that is the way forward. We want to escalate this practice to make it institutionalized model, capacity building of the alumni, development of standard teaching protocols, strengthening simulation-based learning, use of digital platforms, and strengthening the alumni engagement. So I thank ANEI for giving me this confidence and the opportunity to present a small but the real-time project in front of you all. Thank you so much.
Thank you, Ms. Delphina, ma'am, for your presentation. We shall now move to the Nursing Operational Efficiency Challenge, the second competition under ANEI competitions. And kindly note, the jury on the dais will also be judging this set of competition. It is now my privilege to invite our first finalist, Ms. Poonam Talreja, Chief of Nursing Services, HCG, Astha Cancer Center, Ahmedabad. We welcome you, ma'am.
Good morning, all. I would like to thank Annie for giving me this opportunity. My study was on daycare unit. I am working in oncology units, and I have challenges to start a pre-medication before pre-medication in the chemotherapy patients. So there were so many challenges we found out, and at the end, what happened, chemotherapy daycare, patient came and taken chemotherapy, and they have 4 hours or 6 hours cycle. But because of the operational challenges, there may be a delay in starting of pre-medication, and it results for the discharge delay and results the patient dissatisfaction. So my study was to assess the effectiveness of focus intervention to initiate pre-medication administration among patients admitted in daycare, thus by reducing the turnaround time from admission to first contact intervention. Because my aim was to reduce the turnaround time for initiate the pre-medication of chemotherapy patient. The aim to study an evaluation of the effectiveness of focus intervention in facilitating timely initiation of pre-medication and reducing the turnaround time. The objectives are to analyze the contributory factors, policy deviation to intimate the chemotherapy drug administration, to assess the existing practice of initiating a pre-chemotherapy drug administration, and to develop the focus intervention on the contributory factors to achieve 30 minutes of turnaround time. To evaluate the effectiveness of focus intervention, focus intervention on initiating the pre-medication administration, and to compare and contrast the satisfaction score of patient and nurses on focus intervention. Because of the delay in pre-medication, there will be a dissatisfaction in patient as well as in the nursing. We take the study in chemotherapy daycare unit, and our population is who admitted in the daycare chemotherapy department, and our sample size was 150 and duration was 6 months. The sampling technique was purposive sampling, and data collection through the self-structure checklist and related for the chemotherapy medication administration. Data collection, we use direct observation, and patient and nurse satisfaction survey will be done using Likert scale. We use this structure checklist for the data collection. In that, we include patients are scheduled appropriately, because we found that patients are not scheduled properly. All patients come together. So these are the checklist point. Pre-chemotherapy assessment was done or not, because it is a mandatory requirement before chemotherapy. It should be assessed by the nurse as well as by the medical officer. Doctors review and approved for the pre-medication order written given or not. Pre-medication are ordered and indented by the nursing on time or not. Stock levels of essential pre-medications are available in the department or not. And pre-medications are administered within the recommended time frame. And communication among doctors, nursing, pharmacy staff regarding the pre-chemotherapy drug is clearly and timely, because we came to know that starting of pre-medication, there is an involvement of nursing medical officer, pharmacy, and consultant. So these are our satisfaction survey point that patients, for the nurses, that patients are coming in within 5 minutes because nurses have get time for the initiation, assessment, vital taking, IV cannulation. So minimum gap should be there. If all patients come together, then 1 or 2 nurse or 3 nurse can't take all the things together. So patient registration assisted on time or not, pre-chemotherapy assessment done, and dedicated resources are available. Pre-medication kits received from the pharmacy and use the substore efficiently. For the patient satisfaction survey, we use the head patient guided properly, head patient had guided that you have to come on this time, and was your waiting time is reasonable or not. Doctor explained the procedure properly, or the concern was addressed or not, and the pre-medication is informed to you, is it started on time, and the satisfaction level of the patient. These are the inclusion criteria. We included all patients who came in daycare chemotherapy and who are willing, and exclusion criteria for all other areas exception for IP patients and who are not willing. We did this study in a 3-phase, like we collect pre-data collection and survey satisfaction from 1st January to 28th February. Then we implemented the focus intervention and analyzed the pre-data and patient satisfaction from nurses and doctors and patients from 15th March to 15th April. And after post-collection data, we take from 16th April to 31st May. And in last phase, analysis of post data and patient satisfaction and nursing satisfaction from 1st June to 15th June. These are the root cause for delay in pre-medication starting, that improper scheduling of patient by operation staff, delay in patient pre-assessment by doctor and indenting by the nurses, lack of defined workflow, unclear communication between nurse, doctor and pharmacy team, material unavailability of the proper stock of pre-medication. There is a lacking of computer. That's why the nurses have a delay for the indenting, and the environment high patient flow, because all daycare patients came in morning shift. These are the pre-intervention analysis. It shows that all the factors, like I mentioned earlier, that it is assessed earlier or not, pre-medication are available or not, indent on proper time. So it shows that all the data are below the 70%. Then we start the standardized pre-medication workflow. In that, the turnaround time checkpoints were made, the patient arrival time, doctor assessment time, drug indent time, pharmacy dispatch time, and the pre-medication administration time. Refine the process based on learning, that predefined allocation of patient, that operation staff are included in that they have to schedule the patient, and prior on before the admission they have communicate with patient for the admission of the patient to for admission within the gap of 5 minutes. Increase the substore for 4 patients, and pharmacy department extended their support by providing a 15 sets of pre-medication each day to ensure the adherence to turnaround time. And one more computer added to maintain the indenting on time, and medication indenting training given. Dedicated staff for indenting, there is a medication nurse is there, so she is cross-verifying before dispatching from the pharmacy, and monitor the daily feedback from patient as well as from the nurse. These are the results after starting our all aspects, that we increased from 95, the patient is scheduled 95% properly. Assessment was done on time, 97%. Doctor's review, 96%. Pre-medication indented on time, 96%. And medications are dispatched by pharmacy team is 95%. Stock efficiency is 95%. And our pre-medication chemotherapy in start 97%. These are the data from the patient satisfaction survey. As you can see, that pre-data, the disagree level and the strongly disagree level was high, but in the post-intervention, my patients strong agree was very high. So patients were satisfied because treatment start on time, patient discharge on time, so they were very satisfied with that. These are the nursing satisfaction because, as I mentioned earlier, because of the delay, the questions were raised to the nursing only. But because of this study, we have came out that there is no issue only for nurses. There are so many challenges for overcome to this turnaround time. So because of that, our nurses were also dissatisfied. But after the study, because everyone is in a one line and we can reach the turnaround time within 30 minutes, so our nurses are very satisfied for this workflow. These are our time that from 40 minutes we came to the 16 minutes in August. And overall, average time, when we start the study, it was a 1 hour 11 minutes, and at the end of the study, we reached average time is 23 minutes. The present study demonstrates that the significant reduction of the average turnaround time, medication administration from 1 hour 11 minutes to the 23 minutes, from the operational perspective, the intervention improved staff efficiency by reducing the delays, clarifying roles, and standardize the procedures. The likely decrease the work-related stress and improve the task prioritization. Furthermore, shorter waiting times and smoother processes contributing the higher patient satisfaction as patient experience more timely care and reduce anxiety with delays. Yes, 1 minute. So this is the way forward, the strengthening the digital tracking, strengthen the multidisciplinary team involvement, benchmark for national and international standards, and patient education for pre-visit preparation and PDCA cycles. These are our reference. Thank you for attention.
Thank you, Ms. Poonam ma'am, for your presentation. Our next finalist is Ms. B. Mahalakshmi, Chief Nursing Officer, KMC Specialty Hospital, Tamil Nadu, and Vice President, Tamil Nadu and Puducherry Chapter, ANEI. May I invite B. Mahalakshmi ma'am to deliver her presentation.
Very good morning to one and all gathered here. So I will not take much time. I will keep up the time. My presentation is about how to enhance the nursing operational efficiency with standardizing the workflow for the nurses and smart automation. So every time we used to say saving time for the nurses definitely will improve the patient's direct patient care. So we have to reduce the unnecessary time delay for the services. Thereby we can improve the operational efficiency. The problem what we have identified, there are a lot of delays happening in the day-to-day activities in the patient care settings. So we have identified the most important 3 problems. So those are, the first thing is the problem which is significant time delays because of the routine clinical activities due to non-standardized processes, manual monitoring requirements, and inefficient coordination during the doctor rounds. These are the major problems we have identified. So we'll see one by one. So during the rounds, almost the doctors, we are running about 15 DNB PG courses across Kaveri group of hospitals. So we have around 70 to 100 PGs first year, second year and third years. So every time, whenever the PGs are coming for assessing the patient or to analyze the progress of the patients, the nurses are requested to accompany the doctors, PGs, first year, second year, third year, and the registers, even for the junior consultant and senior consultants. That merely takes the nurses' time almost 2 hours. The nurses are working for 7 hours or 7:30 hours, but about 2 hours, the doctor's rounds, they are taking 2 hours from the nurses' time. Next comes the drip monitoring. Of course, we are giving IV medications, IV fluids for the patients. Almost out of 10 patients, 6 or 7 patients may have this infusions. So every time the nurses may calculate accurately and set the flow rate. But in spite of that, the patient relatives or the bystanders, they used to call the nurses and check the flow. So they have the doubt whether the flow is there or not. It is operated manually. So that problem again comes. So this will also take nurses' time approximately 30 minutes. And the third one is doing the non-clinical activities. Since yesterday we are continuously talking about the non-clinical activities done by the nurses that has to be eliminated as far as it is not in our concern or not in our per se. Okay, so for the non-clinical activities, almost the nurses are spending, we have calculated around 60 minutes during her shift. So these are the problems we have identified. The aim, definitely it will improve the patient care quality by streamlining the routine processes, optimizing the coordination between the nursing and doctor rounds, and implementing the automated IV drip monitoring will definitely reduce the time delay, and thereby it will enhance the nursing operational efficiency. The objectives are streamlining the nursing workflow, improving the efficiency during the doctor's rounds, and automating the IV drip monitoring system. The methodologies. There are few hospitals which are adhering to the 5S and the lean management in the clinical settings. So the Kaveri Hospital is one among the hospitals. We have implemented many initiatives based on the 5S and the lean management in the clinical setups. So here also we have followed the same methodology, the 5S and lean. The one important thing is saving time is one of the most important principle from the 5S and the lean management. One more thing we have analyzed, value-added activities versus non-value added activities. Then process mapping. These are the methodologies we have followed. As we know, this is the daily workflow for the nurses. There are value-added activities and non-value-added activities. In the value-added activities, still the non-value-added activities are also included. For example, during a doctor's rounds is the actually it is a value-added service for the patients. But going for a rounds for about 1 hour, definitely the repetition of the work is also a non-value-added activity. So that is we have identified as NVA. Then comes monitoring. Of course, nurses are monitoring different procedures, checking vital signs, everything. But for this IV drip monitoring alone, nurses spending time because of the patient's unawareness and the family unawareness. The third one is the communication. Of course, for the non-clinical activities, so though we have explained to the patients and the patients bystanders, they used to call the nurses for each and everything because they know the person in front of the patient or the family members, always it is nurse. Though the doctor is coming and going, the technicians are coming and going, the other operational people are coming and going, but they have the one person in their thought is always nurses. So they used to call for any activities, they'll first call the nurses. So these are the 3 areas, the non-value added activities are identified. So this is the before and after doctor's rounds efficiency. Previously I told you, the doctors, the PG doctors, the first year, second year, third year, and the junior consultant, registrar, senior consultants. Everybody come for rounds at their time. But here the nurses' time are taking more than what is to be taken care. So in the after process, we have discussed with the HODs of the department, especially with the orthopedics, plastic surgery and the surgical department now. So we have discussed with the HODs and we have escalated the problem, how we are spending time for their rounds. So we have made it mandatory that only the nurse should accompany the HOD of the department, not with the PGs. The PGs can come, they can do the assessment, they can evaluate the patient, and they can document in the documentation record. And if there is a need, they can inform the nurse on the duty or the assigned nurse for any investigations, for any. Again, there was a problem. So the first PG will say something, the second PG will say something, and the registrar will say something. So at last the HOD comes, no, don't do all these things. So again we need to cancel everything. This is again the time waste for the nurses. So that we have discussed with the HODs and they have accepted our problem and they have accepted for single rounds that is done by the HOD of the department. This is one simple, it seems to be simple, but it is very hard to implement because it is related to the doctors. The second one is drip monitoring. So many of us knows nowadays the monitoring is based on the sensor flow. So based on the sensor flow, we can get the alerts and the nurse go and attend immediately, rectify the issues. The third one is, this is important, dial 247. For any activities, the nurse or the patient, they can dial just 247. The nurse, related to the clinical activities, the nurse use this 247. For non-clinical activities, we used to educate our patients at the time of admission itself regarding this 247. Whatever the non-clinical activities related to the maintenance, housekeeping, food and beverages, they can directly dial 247 and they can raise their questions or the inquiries that will be addressed through the supervisor. We have developed our in-house app. This is our app. This is how it works. So by implementing all these 3 initiatives to improve the nursing operational efficiency, we have almost saved 120 minutes to reduced 120 minutes to 20 minutes for the rounds and 30 minutes to 2 minutes for the drip monitoring, and by using for avoiding the non-clinical activities, so we have reduced 60 minutes to 5 minutes. So almost 2 to 2.5 hours the time was saved for the nurses. This will definitely reduce the burnout for the nurses and they can improve their direct patient care services. Definitely a smart workflow design and automation can transform nursing efficiency, allowing nurses to focus on what truly matters, that is direct patient care. Way forward, we are going to have this AI-based tools for improving the nursing efficiency, especially saving the time for the nurses, and they can focus more on the patient care activities. Thank you for the opportunity. Thank you, Annie.
Thank you, Ms. B. Mahalakshmi ma'am, for your presentation. With that, we come to the conclusion of the competition presentations. Before we conclude this segment, I would like to invite Dr. Falakshi Manjrekar ma'am, Director Nursing, PD Hinduja Hospital and Medical Research Center, Mumbai, who would like to share a few words with us. Ma'am? Okay.
A very good morning to all. Congratulations, Annie, especially the Executive Board, our President, Ma'am Ajita, Ma'am Tangam, and the entire Maharashtra group for making this happen. The entire competition was extremely innovative for the simple reason that the jury must have had a tough time to decide that these are the finalists. We were very happy, myself, Dr. Rita Lakhani, and Major Ranjana Williams to be here. Primarily when we spoke about our first issue, the entire concept of coming together, College of Nursing and the clinical service, that itself is an age-old gap which has been prominently existing in the Indian nursing services for the past 100 years or more. Are both presentations by Dr. Dolly Biswas as well as Delphina Gurau brought in excellent strategies. The first strategies was on the principle of mentorship, which is such an innovative idea and very sustainable. I'm sure if we want to implement it, it will go a long way. The second strategy was to use our extremely rich alumni, which I'm sure each and every College of Nursing is very, very proud of, to ask them to come and strategize innovative practices in multifocal as well as multidisciplinary nursing initiatives along with the student nurses. I'm sure the student nurse must have benefited magnanimously. Congratulations for both the presentations. We were very happy to be a part of it, and both of them definitely deserve a round of applause because according to all of us, both of them are definitely winners. We were very happy to see the operational efficiency being presented for nurses. Nurses actually are like, a typical way of describing a nurse is a goddess with 8 hands. At a time, she has to use all her 8 hands and perform 8 activities. Out of that, maybe one of the activity could be nursing. I was very happy to see an extremely innovative project in the administration of daycare chemotherapy project being presented by Poonam Talreja so effectively. A very, very excellent model, and I'm sure it will go a long way if we want to implement it, because these are patients who come to us with cancer, and helping them leave the hospital in a short period of time with a small tatra or performing these innovative activities would go a long way. A very excellent activity initiated by Mahalakshmi, who was innovative enough to initiate an app and decide something which all of us are definitely troubled about. She spoke about IV round, she spoke about doctors, not one doctor, multiple doctors, one nurse, and some excellent innovative practices. I'm sure if we are able to take that forward and pick up a post activity which decreases the nurse's time, increases better nurse satisfaction, and betters patient outcome, what else do we want? Congratulations to all the finalists for presenting some excellent ideas and helping us to take these home, and definitely we are really going to go a long way. Thank you, Annie, for creating this platform. Me, Dr. Rita Lakhani and Major Williams are very happy to be here. Maybe they could like to say a sentence to conclude.
So good afternoon, everyone, and thank you, Annie, the President Annie, and the executive committee members for having all of us here. A wonderful platform indeed. And we as nurse leaders are seated here, and whilst we also seeing, watching our Gen Z, watching them seated here on the stage was a transformation, I feel. And I think so. These two competitions which we face every day, the nursing engagement and the operational efficiency, this has been outstanding. So I congratulate all the 4 speakers over here, and I think so today we have a lot to take away from here. Thank you so much. Thank you.
I think I'll conclude just by saying a big thank you to the Annie team, organizing team, Dr. Ajita, and all of you all over here. Thank you for allowing us to be a jury over here and attending to such wonderful presentations. Thank you.
Thank you, ma'am. We sincerely thank all our finalists for their enthusiastic participation and for sharing their innovative ideas and best practices. Also, heartfelt appreciation also goes to our esteemed jury members. May we give them a big round of applause.